Welcome to the Vital Spirit podcast. I'm Dr. Kelly Livingston, a naturopathic physician and your guide to a new health reality, one that connects body, mind, and spirit. Together, we'll dive deep into the art and science of holistic healing. Through working with hundreds of women through midlife transitions, I've discovered something profound. Most of our physical and emotional challenges are rooted in a maladaptive stress response, and true healing begins when we regulate our nervous system. Each episode will explore complex health topics in simple, empowering ways, uncover the deeper wisdom within each of us, and share practical tools for nervous system regulation to help you awaken your vital force and create lasting wellness. So, if you're ready to reconnect with yourself, your health, and your purpose, let's begin this journey together so you can experience life more fully human and deeply healed. Hi, and welcome back to the Vital Spirit podcast. I'm Dr. Kelly Livingston. Today, we're beginning a two-part series on inflammatory bowel disease, or IBD. And this series is long overdue. Not because IBD is rare. If you've been following along, then you know that I've been talking about IBS, the gut-brain axis, and IBD, but because it is misunderstood, and it is a source of frustration for so many of the patients that walk into my clinic. This conversation has been incomplete, in my opinion, in conventional medicine, and incomplete conversations create unnecessary fear, dependency, and hopelessness in patients. So as always, with anything I share, it is not about anti-anything or rejecting conventional medicine. It is not anti-medication. It is not about false promises or miracle overnight cures, right? But it is about expanding the lens and the conversation around root cause medicine. It definitely is about understanding IBD as a gut, immune, nervous system, psycho-emotional condition. And it is one that unfolds over time. Because I've been a practitioner who sees all age ranges, all sexes, and many different diagnoses, especially chronic GI conditions, especially autoimmune disease in the course of my career, I've been able to see how this condition unfolds over time, how we can prevent it, and how we can reverse it. And very often in midlife, alongside hormonal shifts, chronic stress, identity transitions, grief, trauma, and burnout, this is the time when autoimmune disease, especially IBD, flares. I could even go so far as to say that inflammatory bowel disease and chronic GI conditions and complex GI cases are ultimately why I founded the Vital Spirit method, because the frameworks that I was taught were not sufficient to hold what I was seeing clinically. There were so many moving parts and pieces to these cases, and I really needed a framework, a roadmap, or a container, essentially, to not only convey the next steps of the journey to you as patients, but also to make sure that I was methodical as a clinician and I was really addressing the root cause. Before we go any further, I will say that if you have not listened to the Gut-Brain Axis series and the IBS episode, I strongly recommend pausing and going back. Whether or not you struggle with inflammatory bowel disease or chronic GI symptoms, if you are a patient of mine, we are going to work on the gut-brain axis. So understanding what that means in the context of what your health awakening journey looks like is really important if you're working on mental health, hormones, stress, sleep. The gut-brain axis is playing a key role in all of it. Those previous episodes lay the physiological and neurological groundwork that this series is going to build on. So you can certainly listen here without them. Maybe you are someone with a new IBD diagnosis, or maybe you've been someone who's looking into other ways to treat your IBD symptoms, or even going further and looking at root causes. So yes, you can start here, you can listen here, but it will land much more deeply if you do have the background from those previous episodes. So over the last 13 years as a naturopathic physician, I have been working with ulcerative colitis, Crohn's disease, IBS that we eventually discovered was IBD, IBS that mimicked IBD but never became IBD, autoimmune disease overlap, so thyroiditis or MS or RA along with IBD, perimenopausal gut flares, diverticulitis, diverticulosis, reflux, constipation, SIBO. Definitely mood disorders driven by gut-brain inflammation, and certainly hormonal collapse that follows chronic gut dysfunction. So we've talked all about the estrobolome and the role that the gut plays in hormone metabolism. All of this is what made it so clear to me, this one truth, that IBD does not live in isolation. So any of my inflammatory bowel disease patients are getting a true holistic workup, and we are not just tracking their IBD labs. Inflammatory bowel disease does not only exist in the colon. It does not exist isolated in the immune system, and it doesn't only exist in our genetic makeup. Our genes certainly load the gun, but they don't pull the trigger. It really does reside in our whole terrain. We've talked about this before, right? Our terrain includes our immune system, our nervous system regulation, hormonal signaling in our body, our microbiome ecology, our digestive capacity, stress physiology, our stress responses, our ability to emotionally process. Safety in the body is part of our terrain, and certainly our identity. So this is why simply saying inflammatory bowel disease is autoimmune, here's your medication to suppress your immune system, is not enough. Medication can be necessary. There sometimes is a time and place to have that discussion. It can be life-saving, but it's not on its own a complete healing strategy. There are plenty of times where I'm counseling patients the role that medication might play in their journey, but there's so much else that can be done. So before we go any further, we need to clearly define what we mean when we say inflammatory bowel disease. IBD is not just one disease. It's an umbrella term for a group of chronic immune-mediated inflammatory conditions of the gastrointestinal tract that are characterized by objective inflammation, so inflammation we can see on labs, not just symptoms. Unlike functional bowel disorders, remember, like we talked about in the case of IBS, IBD involves ongoing immune activation, breakdown of your immune tolerance, inflammatory damage to the gut lining, and risk of structural injury over time if not addressed. So inflammatory bowel disease does exist on a spectrum, and the subtype that you've been diagnosed with does matter, not just for sake of diagnosis, but for prognosis, for treatment decisions, and certainly for how we support long-term healing. And in my toolbox, the type of IBD that a patient has definitely will direct my dietary recommendations, sometimes the herbs that I'm going to utilize, even homeopathy and chemotherapy. And given that I have a long history of treating patients with IBD, there will always be, in my mind, a little link when I see a patient presentation that maybe is similar to something that I've dealt with before, where I say, okay, let me go back and think about what I did with that patient that worked so well. And let me check if that might be something that I use in this patient as well. So it's unique to you as the patient, what we find in your labs, your story. But I also love that I have this little catalog of patient cases and histories, which I'll share more with you, that I can go back to and reference and say, oh yeah, that reminds me of this patient that I had, with X, Y, and Z symptom before. Okay, so there are two main primary subtypes of IBD that I see in clinic: ulcerative colitis, and ulcerative colitis affects the colon, and it begins at the rectum and extends upward in a continuous pattern. So the inflammation in ulcerative colitis is limited to the mucosal and submucosal layers of the GI tract, and it's continuous rather than patchy on imaging. Clinically, this can show up as bloody or mucousy stool. Sorry, we talk a lot about poop here. Urgency to have a bowel movement, sometimes diarrhea, which can alternate with constipation. And certainly these patients also usually have some fatigue related to inflammation, and if this has been going on for a long time, related to micronutrient loss or iron loss. From a terrain perspective, ulcerative colitis is tied to intestinal barrier breakdown. So I'm always thinking around patterns of colitis or ulceration or tissue breakdown and damage. It's related to altered microbiome signaling. Of course, we're running poop tests in these cases, right? And loss of immune tolerance at the mucosal surface. So, we talked a lot about tolerance in my interview with Dr. Nash. So, if you've been listening along, you might think, oh, this could be a time for drainage or gemotherapy or some of that work on tolerance, essentially. And importantly, ulcerative colitis has one of the strongest documented relationships to diet, microbiome modulation, and mucosal healing strategies in the research when approached thoughtfully and safely, of course. So, yes, there's so much more to do than just suppressing your immune system with a medication. Now, this is different from Crohn's disease. Crohn's disease is more variable and sometimes can be a little bit more complex, but depends on the patient. It can affect any part of the GI tract from mouth to butt, and it's most commonly in the terminal ileum and colon, so lower down. And inflammation in Crohn's disease is usually patchy rather than continuous like it is in UC. And it's transmural, meaning it can involve the full thickness of the intestinal wall. So this is why Crohn's disease carries a higher risk of strictures and fistulas and abscesses and definitely malabsorption. I will often see that micronutrients are depleted in Crohn's patients. And clinically, Crohn's disease can present with abdominal pain. Pain is often something that these patients will experience. Diarrhea with or without blood, weight loss, nutrient deficiencies, like I mentioned before, and systemic fatigue and inflammation. From a terrain perspective, Crohn's disease often reflects deeper immune dysregulation, greater microbiome disruption, higher inflammatory burden, and more pronounced nutrient depletion. Now, this does not mean that Crohn's disease is hopeless, not by any means, but it does mean that it often requires layered, sometimes longer term, and definitely carefully sequenced care. I am always also assessing for celiac. It commonly goes hand in hand with Crohn's disease and with inflammatory bowel disease in general. Gluten and sometimes other grains are not the best friend of an inflammatory bowel disease patient when they first walk into my office. They may be able to add some of these things back in, but I do want to say that up front that these do tend to be inflammatory foods for IBD patients. You might also hear of IBD unclassified when inflammation is present, but features don't clearly meet those criteria early on, especially not on imaging or gold standard testing. And oftentimes I'll have patients who maybe have elevated calprotectin or antibodies, but again, they're not meeting that criteria for a diagnosis from their gastroenterologist. We'll talk a little bit more about labs in just a minute. And you might have heard of microscopic colitis, which is a distinct inflammatory condition that can be missed unless biopsies are taken. So there's a huge overlap in the population. So some patients are living in this gray zone between IBS and immune reactive gut states. I talked some about this in the IBS episode. Some patients have post-infectious inflammation that can be labeled as IBD. So after an infection, especially something like C. diff, we can see elevated calprotectin, or in long-term H. pylori infections. Those are a little more nuanced than this episode's going to go in depth around. And certainly there might be a patient population that I'll see where it's kind of early on in an IBD diagnosis, and they might not meet every criteria, but I'm still going to work them through the therapeutic order. And remember, there is a difference between IBD and IBS, right? So IBS, irritable bowel syndrome, is a functional bowel disorder where structure looks normal, function is altered. IBD is inflammatory, immune-mediated disease. There's objective inflammation on labs, there's immune activation, and there's a tissue vulnerability and risk of long-term damage. So this distinction definitely matters, but like we talked about in the gut-brain axis and IBS episode, IBS and IBD both live on the same gut-brain immune continuum. And definitely they're both shaped by autonomic nervous system tone, so the state of your nervous system, your ability to regulate and get in and out of parasympathetic and sympathetic, stress physiology, food and digestive ability. Both are shaped by microbial signaling and the health of your microbiome. Hormonal transitions will impact fluctuations of both, and life experience and trauma. So IBD is not IBS with anxiety, and IBS is not a version of IBD. They are very distinct and different. I will say that both of them do tend to involve a loss of tolerance. So sometimes I'll use the term our bucket is overflowing, and at midlife especially, things like food allergies or stress responses, essentially the things that you've been doing your whole life are now contributing to a bucket overload and symptoms. And remember, symptoms are your body communicating something to you. So, the first question I always ask when someone sits across from me with an IBD diagnosis or suspected IBD, or we found elevated calprotectin and antibodies on their blood work, calprotectin in their stool and antibodies on their blood work, the first question is not what medication are you on, although typically if they've seen a conventional GI doctor, they've been told that medication is the only route that they can go. And the first question I ask is not even what diet are you following? It is what is driving inflammation in your body. Remember, pillar one, recognize and remove sources of inflammation, because inflammation is not a single thing. Until we identify the dominant drivers, we're kind of guessing at how to reduce inflammation. So what are the sources of inflammation? And clinically, IBD is rarely caused by one factor alone. So it reflects a layered breakdown over time. So this does include food-driven inflammation. Those can be the classic inflammatory foods. Those can be individual food allergies or sensitivities. It does include loss of immune tolerance. I always talk about that autoimmune bonfire, right? So what things are upregulating our immune system and what have we lost tolerance to? It does include microbiome disruption and dysbiosis typically, gut barrier breakdown, so an increase in intestinal permeability, nervous system threat signaling, especially excessively high cortisol is going to also contribute to that intestinal permeability. It's going to break down that gut barrier. And hormonal transitions, right? So as our hormones fluctuate, as our chronic stress physiology maybe gets even higher because we have more things going on in midlife than we can handle, all of this contributes to that loss of a sense of safety. It contributes to not getting into the parasympathetic rest and digest state. And it contributes to a breakdown of not only healthy immune function, but just even that gut integrity and that gut barrier. And for so many patients, inflammation is truly food driven. So if you can pull out some of those inflammatory foods immediately and start working on healing that gut, well, guess what? Now, every time you eat, you don't have food antigens passing into the bloodstream to trigger the immune system. Now, even if you have a dysbiosis, or maybe you have a bacteria that's releasing lipopolysaccharides or endotoxins and contributing to that leaky gut, but now you don't have as much of that leaking in to the blood and to the immune system. So you're going to start calming down that hyper reactive immune response. All of this is so important to focus on in the beginning and figure out what foods are contributing. So this brings a lot of hope to IBD patients when they hear, oh, my microbiome, so the bacteria, good and bad in my gut, are contributing. The food I eat is contributing, and there's things that I can do about it. Because not every inflammatory bowel disease case has complex trauma. Some do, but not all. Not every case requires years of deep psychological excavation or nervous system regulation. And I would definitely say that just because you have the genes or the predisposition, or I like to say you've dug the hole for the bonfire, it doesn't mean that you're going to develop IBD or that you can't reverse the symptoms. So I think that some are really physiologically straightforward once you identify the root causes. Some are complex and layered. But if you can start with figuring out what foods are contributing as your first step, then that's just a really good medicine. It's really good medicine, in my opinion. Now, as you're understanding what diet needs to look like once you've gotten an inflammatory bowel disease diagnosis, because that's, again, going to be very individualized, you can also start working on your microbiome. So the research is so clear. loss of microbial diversity, depletion of anti-inflammatory anaerobes, and expansion or increase of pro-inflammatory organisms, along with impaired short-chain fatty acid production, so especially lower butyrate, for example, on stool, and altered immune signaling are all contributing to IBD. So your microbiome trains your entire immune system. It maintains a healthy gut barrier or lining, and it communicates with your nervous system, remember, via the gut-brain axis. It's also really shaping your stress reactivity, right? So remember, if you have overgrowth, dysbiosis, if you have something in your gut that shouldn't necessarily be there or is triggering a stress response or an immune response, all of this is then going to shape your stress reactivity, communicate to the brain that you're not safe, and create physiological inflammation. So I want to touch even more in depth on butyrate and how diet can really change labs. So butyrate is a short-chain fatty acid produced when beneficial bacteria ferment the fiber that we eat. It's fuel for your colon cells. It's something that I measure in the GI effect stool test in patients, and it really maintains a low oxygen gut environment and suppresses inflammatory signaling. So it's something that is healing our gut, but it's also playing a role in the autoimmune or IBD process. In IBD patients, butyrate producing species are often depleted and will often see low butyrate itself. When that happens, colon cells are shifting metabolism, you get oxygen leaking into the lumen, and inflammatory organisms are super happy, and they take advantage of this. So dietary change can really lower inflammation in some patients because it's going to feed butyrate and increase butyrate. That's just basic physiology. So it's a really impactful move when you can feed butyrate with food. I've talked before about how psyllium is a precursor to butyrate. So if you tolerate it, psyllium fiber is a great addition in these cases. And so many women that come into my office are not getting enough fiber in their diet. So I've talked a lot about how much I love hemp because it's got great fat, it's got fiber, it's got protein. I love using flax and psyllium. So one of the great add-ons before we're even removing things is usually some extra form of fiber in the diet. Now, you do need to be careful if you are an IBD patient or you are a patient who has an inflamed gut. Sometimes there's fiber that we tolerate and some fiber that we don't. Same with fermented foods, which we want in our diet, right? Sometimes there's some that we tolerate and some that we don't. So clinically, I'm really helping each patient figure out what that looks like. But during perimenopause and menopause, this is a time where we really do need to focus on getting enough fiber in our diet. Because remember, our stress tolerance drops. Our bucket is going to overflow more readily. Our window of tolerance is less, right? Our inflammatory threshold is lower. Our sleep might be struggling. And so we're going to be more prone to inflammation and we're getting less into that parasympathetic rest, digest, and heal. We might have shifts and changes in motility. Our estrogen immune signaling is changing. So midlife isn't necessarily causing IBD, but a lot of women who come into my office have, again, this new diagnosis of IBD at midlife. And these are some of the reasons why. It's essentially telling us that our system has been holding too much for too long, just like we talked about in our burnout episodes. And this realization, as I was working with women, it really was one of the seeds of the Vital Spirit method. Now, when I'm working on physical layers or root causes of IBD, I'm absolutely also working on mind, body, spirit, right? So the way that I tend to do that with patients is through the lens of depth psychology. And remember, in depth psychology and in naturopathic medicine, symptoms are communications. IBD often appears in patients who are hyper responsible, high functioning, emotionally contained, and accustomed to overriding their needs. Now, of course, I'm overgeneralizing. I'm just referring to patterns here. This is not to blame at all. It is pattern recognition. And the gut is where we take in, it's where we process, we discern, and we eliminate, right? So if emotional material can't be digested psychologically, then the body will often speak to us. So I'm not saying that IBD is psychosomatic, but it is psyche and soma speaking the same language and communicating something to you. The Vital Spirit method and the pillars that I work patients through emerged from working with complex GI cases and from working with women in perimenopause with chronic and traumatic stress, where gut healing was improving hormones drastically, and nervous system regulation was not only reducing gut flares and reducing inflammatory markers on labs, but again, it was feeding into that healthy hormonal pattern and HPA axis stress response. So, and restoring immune tolerance through restoring stress response was something that I started seeing more and more in patients as I unraveled the root causes in these complex GI cases. So, remission and stabilization of inflammatory bowel disease often went hand in hand inside this framework of holding biology, physiology, psychology, spirit, relationship, regulation. Essentially, the Vital Spirit method was a crucible to kind of throw everything in a pile and say, okay, let's look at the gut. Let's look at inflammation. Let's recognize and remove sources of inflammation. Let's look at our stress responses and our patterns. Let's talk about our circadian rhythm and our HPA axis. Let's work on how we digest, absorb not only our food, but our life. So it really was the foundation for me recognizing that if we went in a certain order and we had predictable next steps and expected outcomes, it was a much more efficient and effective way to work with patients versus run a ton of tests all at once or take all of these supplements or make all of these dietary changes. And this much more precise medicine was really helpful in perimenopause and menopause when things are chaotic anyway. Okay, so thanks for hanging in there through part 1. In part 2, we're going to move into what I do with patients, more moving into what it looks like clinically. We'll talk about labs. We'll talk about sequencing in the healing process, how I actually treat IBD. And we'll definitely get into things like herbs and homeopathy and gemotherapy and diet. So please stay tuned for part 2. And if this resonated or helped you in any way, please share it with someone else who might be struggling with gut health, in particular, inflammatory bowel disease. As always, if you can download and subscribe to the Vital Spirit podcast, it helps us to reach more women. So thank you and have a great day. I'll see you in part 2.